Last talk, last day. Assalamu alaikum. So this is I hope this is the last talk unless you ask me to talk something about something else. I can do that. But this is just an overview and a quick review of anatomy. This is what I've been asked. And I've just done the slides last night. So if you want any additional information, we can do that, and I will show you some CT scans. So if you want to ask me anything on CT, then we can discuss as we go along with the cases. So I think the first important thing when you're reporting a CT, PET CT, or this may be a spect CT of chest, then you need to know your segments. So left lobe, as you know, has got left upper lobe and left lower lobe. So main bronchus comes down, and I'll show you on CT. It divides into two. So upper lobe bronchus comes out. It further divides into two. So it divides into the upper branch and the lower branch. Then the upper branch, if you follow the upper branch, it gives anterior segment and posterior segment. So if you look at this upper lobe branch, then you'll see the difference between the right and the left lobe, because the right lobe will have a separate anterior, apical and posterior. But on the left, it's anterior and the apico-posterior comes off together. And if you look at the lower branch, it gives superior lingular and inferior lingular. How you identify what is inferior? One thing is, if you follow the bronchus, and as it divides, you can differentiate between the inferior lobe and the upper lobe. So lingular comes in the upper lobe. And if you come down into the left lobe bronchus, it divides into segmental bronchi, and the most upper lobe on just adjacent to the oblique fissure is the apical. Some say, Americans, they make it superior segment of the lower lobe. So I normally say it's the apical segment of the lower lobes. And then again it divides into the anterior, posterior and lateral. Looking at the right main bronchus, it divides into right upper bronchus, right middle lobe bronchus and right lower lobe bronchus. So right upper lobe bronchus divides into segmental bronchi, apical, anterior and posterior. So this is the difference between the left and the right. The right has got 3 and the left has got 2. So apico-posterior is combined on the left hand side. The right middle lobe bronchus divides into medial and lateral, and right lower lobe bronchus divides into apical, anterior, posterior, medial and lateral. So you've got 4. Looking at this is a very busy slide. I could not find any better description on internet to describe the nodal stations in the mediastinum. So it's very easy and it's simple, and I normally report them as mediastinum anterior, posterior, and whether these are paratracheal, pretracheal, upper and lower, and then subcarinal or precarinal. So looking at this is the brachiocephalic vein coming from this. The left brachiocephalic joins with the right and forms the SVC. So anything anterior and superior to this is 3A, and we call it prevascular or anterior mediastinum. Anything below this and up to this level, this is the aortic arch, is the upper paratracheal lymph nodes. Yeah? You understand this? So the landmark is, the problem comes what is upper and lower paratracheal. So you've got the brachiocephalic and you've got the aortic arch coming through. So in between these two, these are the upper paratracheal. Below this is the lower paratracheal up to the carina. Normally, for me, it's very easy to say this is the main trachea coming down, divides into the bronchi. So these are the main bronchus. So if there is a note sitting here, I just mentioned it. This is trachea, this is bronchus. So at the junction of the tracheobronchial. So this is tracheobronchial lymph node. But if you are going to be very specific in chest, then you have to mention the stations, and the physician knows what you are talking about. So this is the bronchus going into the lungs, and that's the hilum. So these are the hilar nodes, right and left. This is the bifurcation, and this is subcarinal region. This is basically, this is the aorta coming down, so you can say either para-aortic in the thoracic region, or it could be aortoesophageal because the esophagus is running through here. And anything below this could be, you can mention it when you're describing it because the clinician would want to know what you are talking about, so you have to be slightly more descriptive. So if you are mentioning a node sitting here, I would normally say this is hilum. And if a node sitting here, normally you do see it, that's basically here is the esophagus, and here is the lobe. So it can be an azygo, because the azygous vein is going through from here. So it could be azygoesophageal node, or more commonly it's called infrahilar, right infrahilar or left infrahilar lymph node. So the clinicians would know that you are talking about the hilum, and infra is below, and the node sitting there is infrahilar lymph node. Any questions if you're not clear? No. Good. 5 and 6, yes. So 5 and 6 is the prevascular. So this is a vessel. So this is prevascular. So this is the aortic arch coming through, and it comes down. So normally I say, and that's the pleura coming through here. So normally I would say is prevascular lymph nodes. Yeah? And this one, I didn't say it. So this is the aorta, and probably you have got the pulmonary artery. So it's AP window lymph node. Yeah? You can say it's AP window lymph node, or what I said commonly, this is the trachea, this is the bronchus, so it's the tracheobronchial on the left-hand side. That reflects exactly the same as AP window lymph node. Yeah? This one would be prevascular, yeah. So basically these are anterior mediastinum, yeah? Superior anterior mediastinal lymph nodes. This is very important, and you do commonly see if you're talking about lymphoma, head and neck cancers. So it's very simple. If you look at this, this is the angle of the mandible. This is the ramus and body of the ramus and body of the mandible. You've got the chin anteriorly. So if you divide this, you've got anterior digastric coming down here, and then the posterior digastric there. So anything inside the space is level 1A. So just posterior to the digastric at this region, it will become 1B. Now you've got the hyoid bone, and you've got the cricoid bone, cricohyoid. So hyoid and cricoid bone. So anything between these two is level 3. And if you follow, it's difficult on this, but once I go on to the CT, I will tell you. The landmark is basically looking at the neurovascular or the carotid sheath, the carotid artery and the jugular vein. So if you follow the jugular vein on the cross-section axial scan, I don't know if I got it, no. Anterior to that is 2A, and posterior abutting to it is 2B. And then you need to look at the hyoid bone. So anything above that and below the angle of the mandible, it's all 2. How you define the A and B is if the nodes are sitting anterior to the vessels is A, anything posterior to the vessels is B. If you then come down, so we have talked about 3, and the other landmark is the sternocleidomastoid. So coming from the mastoid process, going into the medial end of the clavicle. So anything posterior to this is the posterior border of the sternocleidomastoid. So that is level 5. Going up is A, but you don't need to define A and B, but just say this is level 5, anything posterior to this. Anything below the hyoid and up to the superior mediastinum is along the sternocleidomastoid is the 4. And in the midline is, if you follow from midline down into the superior mediastinum, is 6. And anything posterior to the retrosternum is 7. Yeah? So the landmarks are the mandible, the angle of the mandible, the hyoid bone, cricothyroid, and so this, anything above and between the hyoid and cricoid bone is 3. Above that and posterior to the angle is 2. Sternocleidomastoid posterior to this is 5. Between the hyoid bone and the superior mediastinum along the sternocleidomastoid is the level 4. In the midline all the way is level 6, and in the superior mediastinum behind the sternum is 7. Yeah? So that's what is from anterior, so that's level 1. So that's level 2. So midline is level 6. And from here to here, that's the bone landmarks, very easy, so that's 3. And always is posterior, so anterior and posterior to the vessels is 2A, 2B. Below that is level 4, and sternum is 7. So it shouldn't be a problem now for reporting. This is a problematic area, liver. If you are doing non-contrast CT, then it becomes very difficult because the landmarks are the portal vein and the hepatic veins. So what you need to, if you are describing the lesion on FDG PET, I try to give the segments. But sometimes people describe it as right lobe, left lobe, bilobar, or superior segment of the right lobe. But if you are going to report and you are going to report PET or spect CT for oncology, then you need to understand it's simple. The only problem where it's confusing is segment 7 and segment 5. 6 is very easy, 8 is very easy, 8 and 4A overlaps. So you can say if you are confused, just put 4A/8, or you can put 7/8, or you can put 7/5. The landmarks, how you describe them, that's the portal vein coming through, dividing into the right and left, the right anterior and posterior, and then the hepatic veins coming down, left and middle and right. So if you see the segments between the left and the, okay, let's start from here. So you come down to the portal vein, then once you have identified the portal vein, then you start cranially. So either you start cranially or caudally. So let's start cranially above. So you go to the portal vein, you identify its branches, so you know the landmark, so that's the site where the portal vein is entering the porta hepatis. So you go above it, then you find a left hepatic vein. So that basically divides the 4A. So you are above the portal, left branch of the portal vein. So you find this left. So between the left, on the left hand side is 2, above the portal vein. And on the right hand side is 4A, above the portal vein. So let's do the upper part first. Now find the middle one. So above the portal vein, it's on the left is 4A, and on the right is 8. And then you find the right. So on the left above the portal vein is 8, and on the left on the right is 7. Now you come down, and then you look at the portal vein, and then below the portal vein and on the right of the left hepatic vein is segment 3. So each segment 3 is the lower part of the liver. 2 is the upper part. So as you come down from the diaphragm, the first part you're going to touch is segment 2, and on the side you will touch segment 8. So that's the dome here. So then again, identify the portal vein, find the middle, and then on the left is 4B. Now looking at on the left hand side, if you look at the middle and the inferior right portal vein, and this is the right hepatic vein coming through. So in between this is the segment 5. Segment 5 is easy. So if you're looking at the axial slice, if you see, identify the gallbladder fossa and follow the gallbladder fossa. So and the segment on the right adjacent to the gallbladder fossa is segment 5. And segment 6 is very easy. The tip on the right hand side of the liver is segment 6. This becomes problem on non-contrast, and it can overlap, sometimes becomes difficult to say whether, because if you look at it, it is, if you identify the IVC, so segment 7 runs along there, and again segment 5 runs along there, the IVC. IVC is here. So anything which is overlapping could be 7 and 5. So this is the axial. So again, if you remember this, so if you look at this, 2, 4A, 8, and 7. So 2, 4A, 8, and 7. So this is above portal vein division. And then this is where it overlaps. So it's just entering into the hilum, and so probably this is the overlap area. So you've got 2, 3 coming in, 4, A and B coming in, 8 and 7 coming in. And then this is the pancreas, this is the splenic artery coming into forming the portal vein. So this is below. So you've got 3, 4B, 5 and 8. So this is just the overlap. Sometimes you get the overlap, so you don't know where you are, so you can just mention 8 and 5, so the clinicians will be, or the surgeons will be aware of that. And 6 and 7. So you've got this IVC, so along the IVC segment, 6 and 7 overlaps. And then if you're coming further down, then it becomes 3. So you are here, B, 6 and 5. So what I said is the lowest most part is 6. So this is very easy, this is very easy. And again, this is somewhere around, there will be gallbladder. So here it will be 5, and this, it will be 4B. Now, oh yeah, number 1 is, I haven't got it here, so it will be this one, the caudate lobe. So where the IVC enters, and then it is separate. It becomes very prominent when the liver starts failing and you have got cirrhosis. So how to identify the patient is developing cirrhosis? You get atrophy of the left lobe, you got hyperplasia of segment 4, and hyperplasia of the caudate. So if the caudate becomes large and liver is still smooth, then you say it's suggestive of early cirrhosis. And segment 1 sits just there at the hilum, just intrahilar region. Lobes. It's easy, you can say upper lobe, lower lobe, upper, anterior, posterior, depending, just vaguely. But if you want to really go into the depth of this, so again, you've got trachea, we are coming down from head and down towards the feet. Craniocaudally, we are going down. So you've got the upper lobe, which is anterior. Sometimes you can see the fissure, which may be a line going through. I'm not sure whether this is, but you follow up and down a line, then you can identify. So this probably, so you've got, this is the upper lobe, and then probably that line, that's the fissure. So that defines the upper and lower lobe segments. But anyway, so looking at it and comparing the both sides, so we are coming down, that's the aortic arch, and the anterior part is the upper lobe bronchus. Upper lobe because it's above the oblique fissure, and upper lobe anterior segment. So we said on the right hand side we have got upper anterior, apical and posterior. So on the left hand side we have got anterior and apico-posterior. So this is the anterior, this is the anterior, and this one here is the apical segment. So as you go on top, this becomes the most apical part, and this also becomes the apical part. It's a bit strange when you're looking at the axial, you say why this one is not apical and this one is not anterior. But you are cutting through in an axis, so you will get here probably if you go down up from here, so this will become the most apical part because lung is like a convex and filling up the cavity of the thorax. So that's the apical, and this could be going into, if you find the fissure, so that becomes the apico-posterior segment. So this one is the upper lobe of the posterior lobe, and this one becomes the upper lobe posterior segment. So this is apico-posterior, that's the anterior, that's the anterior, that's the apical, and that's the posterior. And that's the fissure that is going through. You'll see the fissures on this side. There are two fissures. One is the horizontal fissure, and the other one is the oblique. Obliques are on both sides, and they are oblique running from the T4 down to, and you see it obliquely. So if you follow this, it will go up and down. The horizontal fissure will only be horizontal, and it divides the upper lobe and the middle lobe, and the middle lobe and the lower lobe by the oblique fissure. So again, you've got anterior lobe, anterior segments, IVC, ascending aorta, then the apical segment, posterior segment, and then I showed you the superior segment, so the apical segment of the lower lobe. So if you're coming from top to bottom, just remember the anterior part is the most anterior segment, the middle along the vessels is the apical, and the posterior is posterior. So again, the same anterior, apical, posterior segment, and this is the superior segment coming up. That's the trachea. There's some fluid in it, and that's the esophagus. These are the pulmonary vessels, and that's the bronchus. So always remember, when you're looking at the bronchus and the vessels, the bronchus and vessels should be almost exactly the same size. If you see you shouldn't be able to see bronchus or very thin wall. If you start seeing the bronchus and thick wall and becomes larger than the vessel, that means there is obstruction, there is bronchiectasis, bronchial wall thickening, bronchial wall dilatation. So that reflects bronchiectasis. So now you are at the bifurcation. So the trachea is divided into the right bronchus, left bronchus. As soon as it's divided, it gives the upper lobe bronchus. So in lung, you need to go down to the bifurcation, and then you start start following where this upper lobe bronchus is going. So this gives off the anterior bronchus, and this is dividing into the posterior. So again, this is dividing, but this is the anterior. This is the posterior segment, and this is the lower lobe coming up, and this is the lower lobe coming up on the right-hand side. And just below this is subcarinal region, just above this is subcarinal region. So you've got the aorta there, you've got the pulmonary artery there, so anything in between here is the aortopulmonary window. Anything here is the prevascular region, and what we were talking about, the 3 is, we haven't got it up there, but somewhere up higher up, it will be this area for 3. So this has divided, now it's going into the main bronchus. So again, still you have got anterior. So anterior, just remember, very simple, it runs anteriorly all the way. The apical has disappeared now because you have gone down, and then you have still got posterior segment, which is posterior, and this is the upper lobe posterior segment, and the apical segment of the inferior lobe is coming up. This becomes, so you've got aorta, pulmonary artery dividing into pulmonary, right and left pulmonary artery. This is the descending aorta, and the esophagus will be somewhere around here. And what you see here, as similar to this density, is the azygous vein. So azygous vein comes through, which is lying on the right-hand side, and this, what I was saying, is a zygopulmonary lobe. So any lymph node just inferior to this is a zygoesophageal lymph node or segment. So coming down, you still have got anterior, and now I think probably you can see some probably changes here. Architecture is changing, so you're getting the middle lobe coming out, and you still have got the superior segment. And this is a posterior lobe. Again, anterior, posterior, and apical segment of the lower lobe. So now you've still got the end. So anterior runs all the way anteriorly, all the way down till you get the middle lobe. You can't clearly see the horizontal fissure, but now you've got the middle lobe. And if you follow the bronchus, you will see the middle lobe bronchus, and you've got the middle lobe coming up. Middle lobe has got a medial segment and a lateral segment. So medial segment and the lateral segment, and that's the superior segment or the apical segment of the lower lobe. Same here, anterior. On this side it's the middle lobe, on this side is the lingular lobe. If you don't want to say lingular, you can say that the upper lobe. So it comes into the upper lobe bronchus. So you've got superior lingular and inferior lingular. So inferior lingular is more anteriorly and adjacent to the right ventricle, and the superior lingular is laterally. So if you want to describe this in detail, so you can say this is inferior lingular and this is superior lingular, but you can just say in the lingular segment. But remember this is coming through, this is the anterior segment, but this is going to be taken off by the lingular segment as you go down. So you still, now you see, if you see the difference now, so that was the anterior segment, it disappears, and then you have got the lingular segment and superior. So the superior is coming through, the inferior becomes more medial, and again the medial lobe starts shifting and the lateral starts shifting posteriorly. Just the orientation, and that is the superior segment of the lower lobe. Now you are down, that's the pulmonary veins, that's the left atrium. 4 pulmonary veins enters into the left atrium. The IVC and SVC enters into the right atrium. So you've got now the middle lobe medial segment, you've got lateral segment. So lower lobe, anterior. Now you've finished off with the apical segment. Now you've got the lower lobe coming and lower segment. So you have got anterior, so basal. You call it either, you can say it basal or you can say it lower lobe segments. So lower lobe segments have got anterior, lateral, and posterior basal. And on the other side, you have got posterior basal, lateral, and still you have got the anterior basal segment coming through. And this is lingular. So inferior lingular, the superior has disappeared, and anterior basal, lateral basal, posterior basal. So again, posterior basal, lateral basal, and anterior basal. So it basically is similar. So the fissure would be somewhere here, probably it's there. So again, upper lobe, inferior lingular. So inferior runs to superior, disappears, and the predominant larger portion of the upper lobe, broncholingular segment is the inferior lingular. And then on the other side is the middle lobe lateral segment. This is the medial segment. And the anterior basal, lateral basal, and medial basal. So again, medial, lateral, and anterior basal, medial basal, lateral basal, and posterior basal. Same, posterior basal, lateral basal, medial basal, and anterior basal. So the fissure would be here, and that's the lingular going through. So again, lingular, just the tip. So this basically reflects the lingular, this reflects the medial, and then the rest is the lower lobe. So you've got the dome of the diaphragm. That's the area where you get artifacts. Patient is breathing, CT acquires very quickly when you acquire the FDG, because it takes about 2 minutes to 5 minutes, and the patient is free breathing, so you can have artifact commonly known as banana artifact. It's sometimes difficult to differentiate whether this is a liver lesion or a lung lesion. So it would be prudent to look into the coronal sections of the chest, and sometimes you might be able to differentiate one from the other.